Chapter 33, Oxygenation. So again, in these slides, I do not own this material. That's my disclosure statement, and the recordings are only for my nursing students. So oxygenation requires respiration and ventilation. Respiration in, ventilation of the lungs, and then expiration on the way out. So the pulmonary system is made up of the airway, the lungs, ventilation, movement of air in and out of the lungs, respiration, the exchange of carbon dioxide and oxygen, at the alveolar capillary cell membrane. So all the way down, including cell membranes on this slide, you can see way down into the situation. So coming in the nose, up through down the trachea, into the bronchioles, into the bronchus, into the bronchioles, into the alveolar spaces at the end. Which diagnostic test or exam would be measure a client's level of hypoxemia? Hypoxemia, what do we use? Measure the level of hypoxemia, meaning oxygen level. That would be a pulse ox. A pulse ox would help us determine their level, but ABG would be better, right? So they're trying to trick you there. Hypoxemia, not oxygen level. Oxygen level is your pulse ox. Your chest x-ray will tell you if there's pneumonia or consolidation. Your peak flow rate is for asthmatics. So they're trying to trick you there, right? A diagnostic exam. This is not diagnostic. This is a screener. Okay, so your ABG is the most direct way to tell which level of oxygen is in the blood. So when we talk about respiration, we talk about the rate, the depth, the lung compliance, lung elasticity, and airway resistance. So lung compliance, especially in babies, they tend to not have very compliant lungs if they're less than 36 weeks. They don't have a lot of surfactant. Where on the other end of the scale, old people also may have less lung compliance and elasticity because of hardening, COPD, emphysema, elastic changes. Respiration can be internal and external. And the way that we control our breathing is through lung receptors and chemoreceptors. So chemoreceptors tell us to breathe deeper, faster, and there are also lung receptors. Factors that influence pulmonary function: lifespan, development. This is especially true in kids. Respiratory distress syndrome in your babies. Upper respiratory infections play a big role. Adolescent smoking, smoking all along the lifespan. And then cardiac insufficiency is going to also determine the lung lifespan and development of your lungs. Environmental, stress, allergies, smoke, tanning, chemicals exposure. Tobacco smoke, e-cigarettes. The more we know, the more that we do not want people doing that. And then also some medications will also influence your pulmonary function. So most of the time, the medications that we're talking about are improving our lung compliance. Upper respiratory infections, URIs, colds, rhinosinusitis, pharyngitis, influenza, those kind of things are considered upper respiratory infections. Lower respiratory infections, RSV, that's prevalent in kids. Acute bronchiolitis, bronchitis, and tuberculosis. Pulmonary system abnormalities. Sometimes it's a structure issue, sometimes it's an airway inflammation or obstruction issue, like in asthma. Sometimes it's an alveolar capillary membrane disorder. And then, of course, with surgery is atelectasis. Pulmonary circulation problems, central nervous system problems, neuromuscular. So the abnormalities in the central nervous system, if you get hit on the head, your receptors aren't telling you to breathe. You have hypoxemia. So a 65-year-old with emphysema is referred to you for counseling on activities to promote better health and wellness. So what suggestions would you make to him about smoking? And why would these actions be effective? Just consider what that might be for a test question, what answers they might give you. Suggestions, never ask why. Cut down. Assessing oxygenation status. So this is where we do a physical exam. We're looking at the breathing pattern, the respiratory effort, the pulse oximetry, and using your inspection, palpation, percussion, and auscultation. So you just did that in head-to-toe assessment. So the term cosmol refers to a high-pitched, harsh, crowing inspiratory sound that is due to partial obstruction of the larynx. Is that true or false? Cosmol respirations. What do you know about cosmols? So a high-pitched, harsh crowing, stridor. Cosmols is actually the fruity breath, and the cosmol respirations are key indicators of a DKA, a diabetic ketoacidosis patient. They are short, deep breaths. So again, some of the diagnostic testing that you would see: sputum sample, skin testing for TB, pulse ox, capnography, spirometry, ABGs, and peak flow monitoring. So on your ABGs, you want to look for your PO2 versus your PCO2. Your PCO2 should be between 35 and 45, 45 being alkalytic, acidotic, 35 being alkalotic. So you switch those numbers around. And then analysis and nursing diagnosis that come from this would include airway clearance impairment, breathing pattern impairment, gas exchange impairment, spontaneous ventilation impairment, ventilatory weaning response dysfunction, and aspiration risk. Again, interventions to improve oxygenation would include respiratory meds, nebulizers, inhalers, bronchodilators, corticosteroids, the use of mechanical ventilator, CPAP, BiPAP, ventilators, and then the use of chest tube draining systems to get air or fluid or blood out of the lungs. Promoting respiratory function, you want to prevent healthcare-associated pneumonia. Immunizations, prevent upper respiratory infections. Smoking cessation. Positioning for maximum lung excursion. What does that sound like? High Fowlers. Get them up. Incentive spirometry. Aspiration precautions. You always want to assume if somebody's unconscious that they're also at risk for aspiration. And then to help them mobilize secretions, we tell them to turn and cough and deep breathe. Hydration, hydration, hydration. The more you drink, the more the mucus gets thin, the more you can cough it up. We can also use chest PT, which is chest physiotherapy that's very well known for cystic fibrosis patients, but you put their head down, their butt up, and use your cupped hand or the vest at this point. Oxygen therapy using cannula, mask, transtracheal catheter. So a nurse is teaching their client how to obtain a sputum specimen. In order to provide safe and effective care, the nurse instructs the patient on the following action to facilitate obtaining a specimen. Do you limit fluid intake? Have the client take deep breaths? Ask them to spit into the container? Or suggest to the client that the specimen be obtained after eating? Which one? Well, we don't want spit. We want sputum. Dearly don't want it after they eat. Okay? The optimal time to obtain a specimen is arising on the morning. So sputum can be thinned by fluids. They should not be spitting into it, but the client should be encouraged to cough and deep breathe. The client should rinse their mouth to avoid contamination. And they need to cough up that specimen for us. The use of artificial airways, there are oral pharyngeal airways, there's nasopharyngeal airways, endotracheal tubes, and trach tubes. And then in order to keep artificial airways open, we need to learn to suction, like we did in lab. In caring for a client with a tracheostomy, the nurse would give priority to the nursing diagnosis of at risk for ineffective airway clearance, anxiety related to suctioning, social isolation related to altered body image, or impaired skin integrity. Which one sounds the worst? Tracheostomy, they're at risk for ineffective airway clearance. So excessive secretions is a priority, or else they'll aspirate on them, right? So that's a little taste of oxygenation.